I really had a complete aha moment when I thought this is going to be a revolution.
70 million people worldwide affected by OCD. They can't operate, they can't go to work, they can't live their life with their families.
I wake up every morning feeling extremely grateful that I am working at the cutting edge of something that potentially could change the world.
Hello and welcome to the OCD Conversations, a series exploring new and innovative ways to treat obsessive compulsive disorder, from psychedelics to psychotherapy, deep brain stimulation to ultrasound stimulation, as well as repurposed medications and even computer games. I'll pick the brains of the groundbreaking people who are pushing the boundaries when it comes to OCD treatments. Some of the world's leading specialists who are transforming the way we view and tackle a condition the World Health Organization classifies among the top 10 most disabling illnesses globally, and which affects about 70 million people worldwide. I'm Sean Fletcher. I'm a broadcaster here in the UK. I know we have viewers from around the world, but if you're in the UK, you may have seen me on the BBC's Country File or Good Morning Britain, ITV's breakfast show. But I'm also a father of a son who has obsessive compulsive disorder. Before he was diagnosed, I knew very little about OCD, but as many parents and friends and family of loved ones who are struggling with OCD do often, is my wife and I did everything we could to become experts in OCD. I suppose we could say we're sort of lay experts in OCD, and I'm sure that's a familiar story for many people who know someone who has OCD or have a family member. And since then, I've gone on to become a mental health campaigner with a particular focus on OCD. Now, we have a very special guest today, Professor Elsa Fouragnan from the University of Plymouth, who has been conducting a study into the role ultrasound could play in treating OCD and other mental health disorders. So let's bring her in to the conversation. Hello, Elsa.
Hi.
Good to see you. Could you just start by explaining what it's low intensity ultrasound, isn't it? What is it and how does it work?
Yeah, so ultrasound is quite known in the medical domain, for imaging babies before they're born. So it all depends on how much intensity of ultrasound you're using. So the low intensity range that we're talking about are the same range that you would use for imaging babies in the womb. But in this instance, what we do is that we focus the ultrasound waveform into a specific point. And by doing this, we increase the acoustic energy in that specific point. And if you do it transcranially through the skull, the target of that focus could be a particular part of the brain that you would be interested in modulating. So it's called neuro because of the brain modulation, because we're trying to modulate that part of the brain that we think is responsible for something. Ultrasound can be, low intensity ultrasound can be used for many brain disorder. Obviously, today we're going to talk about OCD.
Before we get into OCD, what are the other things that it could be used for? So you're talking about any mental health condition?
Not just that. We can also think about neurological disorder like essential tremor, Parkinson. There are already invasive forms of brain stimulation that exist that are very useful for treating neurological disorder that are so well circumscribed in terms of where in the brain that pathology arises from, that you can just, for example, use little electrode to go deep in the brain and stimulate the brain region, and you could reduce tremor, for example. So you could do exactly the same with low intensity ultrasound, but it's going to be non-invasive. So for the first time, we can go very deep in the brain with high precision, and we can try to alleviate symptoms. So it's been used already in essential tremor and Parkinson. And now one of my main goals is to bring that forward to mental health, because obviously mental health are also due to dysfunction in brain circuits.
Guys, I'm smiling because it just sounds very futuristic. As a parent, and any parent watching this will know, when you go for your scan, it's that ultrasound, is it? So it's the thing, so my wife, pregnant, they put a little gel on her tummy, and then they use those sort of probe things, and then you suddenly get an image of your baby in the womb. That's what you're talking about.
It's that, and it's not exactly that, because that imaging form, for example, the beam would be moving very fast throughout a distributed area, and therefore there is absolutely zero interaction with the tissue. The only thing you do is really reading echo and taking pictures. So the probe that we use in imaging babies, I was also pregnant, I remember that very clearly, is not enough acoustic energy to actually stimulate the tissue. So obviously here, the tissue that I'm talking about is the brain, and the acoustic energy that we use is just by mean of accumulating the ultrasound to a specific point over time. And our brain cells, neurons and other brain cells, they have those little receptors that are called mechanical-sensitive ion channel, and they sense this pressure, these changes in acoustic pressure, and they start firing, they start communicating. So you can basically, by mean of putting ultrasound into the brain, in a specific part of the brain, you can induce what we call neuroplasticity in the circuit. So the cells are going to start firing and communicating with their neighbors in a different way than they would do normally. And sometimes that's good, because you want them to fire again, or you want them to actually stop firing. So it all depends on the protocol you use, but yeah.
So someone who has who is struggling with OCD in a particular moment, maybe there isn't the neuroplasticity that you would have in that circuit, that key circuit, that it is sort of almost like malfunctioning, which is meaning you're performing obsessions and compulsions, and which is where OCD is affecting the person. What you're doing with the ultrasound is bringing a neuroplasticity which stops that or alleviates that in a way.
Yeah, that's exactly right. So we know, I'm not going to say perfectly, but we know quite well now the underlying dysfunction in the brain circuits of people with OCD, but also other disorders. So it has to do with the prefrontal cortex, this part of the brain that will allow you to ruminate and have ideas and think and thoughts. And also the deeper part of the brain that are called the basal ganglia that would act on certain thoughts. So if you're obsessing about something, the passage to action, or you would say you feel like the compulsion to do certain things, that's more rooted on in deep part of the brain. So it's the relationship between the basal ganglia and the prefrontal cortex that we're trying to massage, if you wish.
It's like a massage in a way. So you might go for a run and have a tight muscle, and you're massaging it to get it to be more active, and that's sort of kind of what you're doing with the brain.
That's exactly right.
I mean, and look, we're both wearing headsets. Is it a bit like just wearing a headset, or is it like the sort of scan that you do when you do the ultrasound scan for a baby? What would it look like?
Yeah, it's a great question. So there are actually a lot of different devices that exist. You can go from something that's called an MR guided multi-hemispherical, and you have like thousands of elements, and it's the entire head that will receive ultrasound through multiple points. That would be like the high standard, super expensive also device. You can have much simpler transducer where you just have a few elements that still allow you to convert, the ultrasonic waves to a specific point. And this will be small, like that, and you can just put it wherever you want in a head. And there are the in-between headsets, sort of helmet that looks potentially like that, where you would have usually through the temple lobe or other parts where you would have all your elements just focusing deep in the brain. So essentially it does look like you're putting something on, and then you'll have to put a bit of gel underneath to do the coupling. It's the same problem of coupling with the belly. You have to have a perfect impedance match between your transducer and the soft tissue. So that's why we put gel. So you would have gel underneath here. And then the software that will come with the device is the one that says, well, we want the phase of the elements to be such that we're going to go here and we're going to use that particular protocol.
So is this something that you could see people having at home? So I could just have it in my kitchen drawer and say, I'm struggling today, I'm going to put it on, or is it something you need to be in a lab for?
Okay, so this is a really fantastic question. I think a lot of us are really thinking about what the future would look like, and I'll explain that there is the one problem of the skull. So we need to understand the skull quite well. So usually we need to image people. We need to put them in the scanner and get their skull information, and also get their brain information, because between you and myself and others, there will be variation in how our brain are and so on. So if you want to be really capitalizing on the fact that this technology is super precise, what you want to do in advance is know, actually, I need your brain data. So I would say, yes, it is possible that you would have it in your home, and you could do it every night, for example, for 30 minutes. But in advance, as the person that programs your intervention or your treatment, I will have to know about your brain. I will have to know about your brain and your skull to make sure that enough energy are going through, and I know exactly where I want to go. Because obviously, as I said, this is personalized neuroscience, personalized medicine. So it is not just going to be, I'm going to buy it on Amazon and I'm going to put it on my head. I think it will be more, there is some steps to follow, after which you can take the device home and you can use it following the instruction of a nurse, for example. Or so I think it's possible that we are going to go towards this direction, and I just really hope that the people that are going to commercialize this thing are never going to bypass the fact that we want to remain super precise, and we want to remain really high standard when it comes to your brain is different than my brain.
And what about people who are watching who will be thinking, I mean, the brain, is obviously a very important thing, and tampering with it, doing stuff to it, it sort of scares them. Is there a danger? Is there a danger that if you say got the wrong area, you start to do weird things or whatever, or it would affect you, or that it would affect you permanently? Is it something that just happens during the time of the treatment?
Very good questions. So if you take a pill, a drug, your entire brain is going to be altered by this chemical. So I think that we're exposing our brain to so much already on a day-to-day basis, that I am a lot less concerned with what we could do by actually just poking to the right region. I think we're going to see less side effect than some pharmaceutical treatment, because we're going to be much more precise. And then you're asking about how long the effect lasts. So the effects that we observe are, we're talking about neuroplasticity. So usually we observe things that are beyond, that are outlasting the intervention period. And what we observe in the lab is with less than 1 minute sonication, we have effect that can last up to 1 or 2 hours. So this is obviously not forever effects, but it's very encouraging to us, because it shows that you have this window of opportunity then where the brain is going to be a bit plastic. Maybe you can engage the person into some cognitive test or certain task that would be beneficial to actually rewire the brain even more. You see what I mean?
So it's like, so the go-to treatment for most people, or for all people with OCD, is SSRIs and therapy. And the SSRIs, so the high dose of antidepressants, basically it brings the noise down, which means the therapy is more effective. And without the SSRIs, the therapy is less likely to be effective. I mean, I'm saying it in a very crude way, but that's sort of what most people who have OCD, if people watching, will be familiar with. It's sort of doing this. The opportunity is to do exactly the same thing, except you're doing it far more targeted, and something that would work for a period of time. But during that time, that's when you leap in there and you get the therapy done, which would be more effective than without it.
That's exactly right. And I think that there's also something I observed, which I was not necessarily expecting with this study that we're running, is that when people have actually experienced symptom release for an hour or two, it just boosts them so much that actually it carry over much longer than actually the time where the neuroplasticity is evident. The symptom reduction is much far more long lasting, which is very, very interesting to me. It's almost like
Wow.
a state switch where people are all of a sudden they are in a different state, and because of that switch they can stay in that state for a bit longer. Yeah, it's
So
something
what,
very
with OCD, are you
interesting.
talking with OCD or with? I
I'm
mean,
talking about OCD here. Yeah.
to someone who struggles with OCD would have come to your trial and had a minute of ultrasound, and you noticed, or they noticed. I mean, we have ways of measuring OCD, and on that scale, their OCD was they were in a much better position. They weren't being affected by it, and you could see that it's sort of an uplift in their mood and so on and so forth.
Exactly.
I mean, that's people listening to that's incredible. I mean, that's sort of great to hear.
It's very
so
humbling
exciting.
too.
Yeah. Wow. So this was on the trial, and it's people with OCD, but also addictions and other all sorts of other things that people are struggling with.
Yeah, I mean, I'll come back to one thing that a person told us that participated in the study, which was really eye-opening to us. It was a she. So she told us that the thought, because she was a checking person, so she used to check things all the time, and even when she came, for example, she gave us her bag and we had to put it in a locker, and she was almost apologetic in advance, saying, "I'm sorry, but I'm going to have to ask you to go and check multiple times during the thing because it's going to bother me," and we were fine with it. But right after the intervention, she told us the thought came because it always does, but I just could let it go. I had the ability to just not care about it. And that was very humbling to us. So the thought was still there. It's the translation of that thought into an action that is undesirable. And this is what I was saying between the prefrontal cortex and the basal ganglia. Julie, this is the act. And it's the same in addiction. So that's also why I'm interested in this.
I mean, this is absolutely fascinating and really encouraging. I mean, I sort of feel like, oh, let's get it on. Let's get this out to people with OCD. But of course, you have to do finish the trials and do lots of tests. We've done some work with Orchard on deep brain stimulation. Is this a bit like that in terms of what the effects are, except it's not as invasive, or is it something very different?
No, it's very common that we do the parallel in my field, because first, there is no other non-invasive brain stimulation technique that can go as deep as ultrasound. So our next the technology that we can compare it to is usually DBS, but obviously DBS is we have to drill through the skull and put an electrode in your brain, and it's permanent. So it's extremely well, not a lot of people can have it. It's very costly. There is risk of infection and so on and so forth. It's not a minimal intervention, and usually only very refractory patient would have it or would be eligible for it. And actually, I don't think OCD is FDA approved in the UK, but Parkinson would be. But anyway, ultrasound is indeed the closest to DBS, but in a non-invasive form. The difference, obviously, is that deep brain stimulation relies on electric activity. So it's electricity that's delivered through the electrodes, whereas ultrasound relies on acoustic energy. But acoustic energy ultimately will interact with the neurons and the brain cells in a way that will lead to an increase in neuronal firing and so on. So ultimately, the result is the same. It's just that it's not the same way to get there.
I mean, so every time you keep answering, and I sort of have visions of us in the future using this and it being a real game changer with OCD. Am I just getting carried away? Is it a game changer? Is this potentially something that could really change the lives of so many people who struggle with OCD?
So I'm going to talk more as a neuroscientist. As a neuroscientist, when I started in this field, which was about 8 years ago, I really had a complete aha moment when I thought this is going to be a revolution, because it's the first time ever that we can go deep in the brain non-invasively with precision. And we were, observing effects that at first I think a lot of us were quite skeptical, thinking, is that really true? and and when we have so much evidence to suggest, yes, it's absolutely true. Ultrasound can induce neuromodulation, and neuromodulation that can be long lasting. So it can be completely a game changer, and not just for people that are obviously suffering, but also to better understand the brain, because we don't fully understand the brain. But now we can explore in a causal fashion how, if you take a healthy person and you start poking this part of the brain and you just observe in their behavior what's changed, all of a sudden you can do a true brain mapping. So both in terms of brain mapping and in terms of treatment, I think ultrasound can just be completely revolutionary.
Until I came across your work, it's not something I'd heard of. Why are not more people doing work in this area? Why have I not heard of it before? Is it just because it's a blind spot for me and I should have heard about it?
No, because it's quite new. It is very new, but it's absolutely exponential, the amount of interest there is for that technology over the last 3-4 years. I mean, the numbers of research laboratories that are using this is exponentially growing. The numbers of companies that have started to create the technology is also growing exponentially. There is really a lot of interest. Ultrasound is not new in the imagination of people when it comes to medical device. We are quite used to ultrasound in the medical world. So I think that actually the translation to being used is going to be quite simple, because people won't be too reluctant. It's not like electric shock. That sounds really scary. Ultrasound is quite nice and well received by patient usually. And I think hopefully the medical care will also think the same, obviously, and they will trust the results we have. And
because that's the sort of image lots of us have when we think about, and I'm saying this as a total outsider and layperson, not a neuroscientist, but when we think about people doing stuff with the brain, I mean, I immediately think of lots of things, but one of them is, the First World War, people who went to the trenches and struggled and had serious PTSD and were having electric shock treatment, or people who have had, serious mental illnesses over history, and they have been treated shockingly because they thought that was the right thing to do, with all sorts of electrodes and all sorts of things like that. Of course, that's in the past, isn't it? This is something that it seems like it's not, it's temporary. It's non-invasive, and it can only be positive. Or have you seen some downsides? Have you seen some side effects? Have you seen some issues that you might have to overcome?
yeah, we could also talk about the fact that we are really a generation that's over medicated, and I think there is something to be said about the fact that we are exposing our brain to a lot of drugs and so on. So it it might be also good to have an alternative method that is a bit less that's not going to affect your entire brain. So, but anyway, side effects. It's almost certain that we're going to have side effects, because if you are, intervening with a part of the brain, even if it's so precise that you think it's only that dysfunction that you're targeting, ultimately it is possible that there will be side effects. But related to the cognitive processes that are at play, if that makes sense, because ultrasound in itself is very well received. There is no side effect as such. It's not like you're going to have a headache or you're going to feel really diseased by the intervention. You actually don't feel much at all. I've done it on myself many, many times. I mean, it is maybe possible that you would have a slight headache. Some people have reported it, but it's extremely rare. So it's usually very, very well supported. But what I was saying in terms of side effect is, for deep brain stimulation, for example, if you want to reduce the tremor, you will have to go to some part of the brain that are highly dopamine driven. So by stimulating those brain regions, it's possible that you make people more impulsive. And that is a side effect. It's the fact that you will have to think very carefully about what could be the downsides of regulating that one cognitive process.
But only for that period of time, though. So the neuroplasticity means that they might be more impulsive, but only for the 5 hours that it's meant to affect. Or are you altering things long term?
Well, we don't think that with the protocol that we're currently using in the study, we're doing anything that's that really is permanent, for sure. We're more in the short-term window. It's a good question. I don't think. So let's think about it for a minute, right? Where if you were to reduce the relationship between a thought and an action, and you're making plasticity in that part of the brain, and it's absolutely great because that person all of a sudden have more control over what action she can or he can perform. Is it possible that in the very, very long term, that person becomes a tiny bit more relaxed about certain things? Maybe.
Yeah.
Maybe it's okay because it's going, like, the cost benefit is going to be so massively, if this person has regained autonomy and complete freedom over what she can do or he can do in his life, then maybe that's okay. You know what I mean?
Yeah, you are changing things, but that's sort of part of the course.
That's what you're trying to do.
Yeah. You're changing someone's life who has been struggling with something. Can you talk me through the trial then? So how many people did you have on it? How long did it take? And you're still doing it, aren't you? There are different phases. Can you tell me where you are in that?
Yeah, we could call it a bit of a proof of concept study. So it's not really large scale. We had 2 phases and we wanted to recruit 30 participants in each phase. The first phase was something we called almost a search phase, where we wanted to see if different parts of the brain had different causal relationship with symptoms. So we wanted to see if by neuromodulating certain parts of the deep brain, we would see differences in symptom reduction, but also in how people were making decisions, because I'm very interested in the neural basis of decision making. So I wanted to see how that was changing the way they were making decisions. And ultimately, I think with that one phase, we wanted to see if it was safe, if we could induce neuroplasticity in the circuit we were interested in, and if there was any form of symptom reduction. And then in the second phase, what we want to do is go a tiny bit deeper in a single brain region, the one that would work best after phase 1. And at this stage, we're going to put people in the scanner after the stimulation, and we're going to try to really see how it has changed their brain connectivity and chemistry, basically.
How do you know that? How do you work that out? Do you scan the brain for differences before and after?
Yeah, that's exactly right. That's exactly right. And also you have a group that receive a placebo and a group that receive a real stimulation. Yeah. So the placebo group receive ultrasound, but it's not focused in any part of the brain. It is diffused. And by means of being unfocused, it doesn't, there is not this accumulation of energy in a particular brain region. So it doesn't do anything. It's like taking pictures. So there will be one group that doesn't receive anything and a group that receives the real treatment.
Yeah. I understand that with OCD, you can identify a particular circuit in the brain that is almost like it's short circuiting. I suppose that's a way of just explaining it to make it easy to understand. But also there'll be a circuit nearby that if someone has an addiction or if a gambling addiction, the same will be happening in that nearby circuit. So similar sorts of things are happening with these conditions that are affecting people's lives, and you can pinpoint the circuit or the area of the brain that you're trying to bring neuroplasticity to through your ultrasound. Is that how it works? Is that too simple a way of looking at it?
It's not. It's very, very close to what we are currently doing. So we've recruited people with particular symptom of OCD, and we categorize them into certain categories. So those that are more like washing type, we have people that have more like checking symptoms or symmetry. And what we do in the scanner prior to the intervention is that we use those images that are going to be quite tailored to that person's OCD. So, they would be exposed to those pictures. So for sure, it's going to activate the circuits that will be personalized to that one person that's observing the things that would usually bother them. And it's the same thing for addiction. So for addiction, you could take the cues, the drug of interest for that one person, and you can just show them some images of those drugs, and usually that elicits strong compulsivity-like behavior, and that's what we want to observe in the scanner. So it's a little bit tough because we're sort of provoking the symptom at first in the first initial baseline scan, but that is gold data for us, because then after that we can really pinpoint to the parts of the brain that were highlighted and potentially dysfunctional.
Yeah. So what's going to happen? So you talked about the phase 1 and phase 2. How long will this take? When will we be able to see the results of this? I mean, the way you sighed there, it sounded like it's a long time. It's a long project, is it? And how long have you been doing it so far?
We started at the end of last summer, and we've only finished phase 1. So, and it's 30 participants, but as I said, they have to come 5 times for 4 different parts of the brain. So we, it just takes quite a long time to acquire those data, but they're very precious data. I'm hoping by the end of this year, we'll be able to publish the phase 1 for sure results, and phase 2 should be largely in the way, if not finished, by the end of the year. So hopefully we can show to the world what we found.
and so this would be almost like a pilot, so that then what would you hope that big pharma would come on board and then do a much bigger trial or whatever, that someone else with the big bucks will come in and will take this to another level? Is that the plan?
Well, the plan, I think, if you want to do really good science, is ultimately you want to do what we would call the multi-center clinical trial, meaning that it's not just one group, it's many groups of researchers that decide to collaborate and run these things on different sites with different populations potentially, or maybe the same population. And then you gather all those data and you create a meta-analysis, and those meta-analyses are usually sent to the FDA or other regulatory bodies. And at this point, they make the decision of whether there is enough evidence to suggest, okay, this is really good, this is really transformative, let's try to implement it. Let's try to put so some law forward so that this can be used actually and maybe reimbursed and so on. It's a very long process. The translation to actually clinical use is it's a bit of a long and painful administrative thing.
But worth it if you manage to get something that is used regularly by lots of people, OCD, but also other conditions. Are you looking for other people to join the trial? Do you need people calling you up and saying, look, I'm here, I'm ready for you to scan my brain, or are you okay with that?
I think we are pretty much okay for phase 2. I know that there is so many people that are very desperate for a new form of treatment, and I hear you guys, if you're listening to us, I know how much suffering there is, and I understand that it would be great to have this large scale, but we just need to, prove that this is effective, and it does take a little bit of time. But I'm quite confident that the field is going to grow quite quickly, and there is, as I said, there is enough investment at the moment from the Research Council, across different countries. Obviously in the US there's a lot of clinical trial ongoing in OCD and addiction and other forms of psychiatric disorder. So I'm really, really hopeful that in the next few years this is something that's going to come as an alternative treatment for some of us that have issues.
Which is what we're trying. One of our main aims on with Orchard is to try and make sure that clinicians have an armory of treatments when someone presents with OCD. And ultrasound would be one of those things that you could say, well, ultrasound works for this person, but SSRIs work with that, and so on and so forth. And at the moment, it just feels like there is just one option, which is the clinicians say SSRIs. and therapy. And that
Mm.
doesn't work for everyone. And actually, we know that what doesn't work for quite a large proportion of people. So that's
Yeah.
where this fits in. Are you saying that this is being done? Are there other areas of the world where this is being trialed? Ultrasound is actually
Yeah, in the
taking place?
UK, I think we're the first one to do it. I'm pretty certain that in the US there are some other parts, but somehow in the US they run study differently than us. But so the same I would not call it a clinical trial. Actually, I would call it a proof of concept study, but they call it a clinical trial. So when you go and actually look, it's only 10 participants that have gone through certain tests. So yeah, there is a little bit of differences between the UK and the US in that respect. Hopefully, let's say in a year or two, we'll be in a position where we can gather all of those data and really showcase that this is working, that there is hope there.
Yeah, when you say there are differences between the US and the UK, that's very topical at the moment, I think, isn't it?
Yes.
Right. I feel like it's really important to get some questions. So people have been
Mhm.
sending questions in. So I'm going to read through them. You can't see them on your screen there, can you? So let me read them out to you. So Margarita's messaged in and said, absolutely fascinating. Thank you very much, Professor Elsa. I was wondering if there is any evidence that focused ultrasound stimulation might also help PTSD symptoms.
No, we haven't done PTSD, but it would be very, very logical that someone look into it. Because again, it relies on the same principles, right? If we know that there is dysfunctions in the brain, if we can identify those, and if we can try to go and induce neuroplasticity in those circuits, then that opens doors for different forms of therapy. Whether it can work completely on itself, it's possible, but my guess is that it would be even more powerful if it was coupled with some sort of CBT, like right after the intervention, right when you are in this window of neuroplasticity. That's my guess.
So I mean, you're talking that you would assume it would work with PTSD, OCD. You've even given us an example of someone. Have you got other stories of people with OCD who say, "You're changing my life by doing this"?
So there is a few, but maybe what was most eye-opening to me was the fact that people would really go through a lot of length to participate in the study, even when we were quite clear, for example, that if you were under current medication, that you wouldn't participate. There were people that came and that tried to hide that they were actually under medication, and it was only after hours and hours of interview and tests that we realized, well, this person is very clearly under some treatment. And
how do you know? How can you tell? You do blood tests, I suppose.
well, yes, there is that, and there is also just, I mean, if you interview someone long enough, you will start knowing what they have tried and for how long. So some people would come and they say, "Oh, I've stopped my SSRI yesterday," and I would be like, "No, no, 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 no! You don't do that. Just go. You don't stop your treatment for this." Also, because we don't know fully. Well, at least at the beginning of the study, we didn't really know if I was going to be helpful at all. We just wanted to see if there was any evidence of neuroplasticity in the circuit of interest. And it wasn't even our primary outcome of the study. The primary outcome of the study was safety and evidence of neuroplasticity in those brain circuits. And then obviously the secondary outcome were whether or not that would alleviate symptoms. So I know that it was very heartbreaking for some people to not participate because they had so high expectation, but those high expectation can also drive placebo effect and so on and so forth. So I think it would, for me at least, it would be better if people came not really expecting too much, and then therefore your results are more clear. But that's just talking from a scientific point of view, right?
Yeah, the story you tell there. I mean, I smiled when you said it. You know that people were hiding the fact that they were on SSRIs, but it also actually is very sad, isn't it, that people are so desperate. They're so desperate, even though they're on a certain treatment, they need something else. And I think that tells you the demand that there are lots of people who. I mean, I talked about it at the beginning of this this webinar. 70 million people worldwide affected by OCD, and they will range from people who are affected a small amount every day to people who are it's totally disabling, that they can't operate, they can't go to work, they can't live their life with their family. So what you are doing is making a big difference. I'm going to keep going with the questions. So Paul Ram has messaged in, what are the options for patients if the ultrasound can't reach the target area? Are there alternative techniques or technologies that could be used?
Right. So in theory, there is no brain region that we cannot target with ultrasound. It all comes down to the hardware that's been used. So as I was saying, predominantly we're being interested in the prefrontal regions, the cingulate regions, and the basal ganglia. So obviously those headsets that I was telling you about, if they are positioned in the temp region, and if they have sufficient elements into them, you can have a 3D steering. So you could do cortical and subcortical and region, but obviously you wouldn't go like at the back of the head. But maybe that's okay, because the visual cortex is maybe not the first thing you want to target with someone suffering from OCD. But if there was conditions for which this is where you want to simulate, it's the back of the head, then you just have to change the hardware.
I see. So there are no areas. There is no area where any condition can hide. You can get to everything.
Pretty much. There are regions that are more tricky than others. For example, we have sinuses here. We have big sinuses, and sinuses are full of air. And air is a big problem with ultrasound propagation because it will reflect back into the transducer. So ideally, you would want to fill those sinuses with some gel, but you can't, of course. So in order to go to, for example, the wall of the orbitofrontal cortex, which is right behind the sinuses, you would have to go through the side. But that's just a matter of being smart and find solutions. That it's pure engineering solutions, right? So I would say that theoretically there is no limit to where we could go.
Yeah. Another one from Margarita. In your study, do you also have patients with covert compulsions? So, for example, praying or counting in their mind, replying to certain conversations in their minds, and then in brackets, non-overt and non-visible behaviors. So I guess that's things like pure OCD, the stuff that you can't see. So it's not like cleaning your worktop. It's that's
yeah.
Yeah.
Pure O is a. I know that a lot of people are suffering from this, multiple forms, but we're not currently, because it's not that many participants. It's only 30. We tried to narrow it down to a few categories, and as I said, we were also using those images in the scanner in their baseline assessment. So because of that, we constrained the study.
Did you specifically pick certain people with certain characteristics, or did you just get a random 30 people and you happen to have 5 of them with OCD? Was it like that? No, we
were very, very specific. We had more than 500 people signing up, and we only welcomed 30.
That's amazing. 500. I'm just thinking 500 Plymouth. So for our worldwide listeners, Plymouth is not a sort of a massive hub. It's a big city. It's a small city down in the southwest, not that close to other big urban areas. Am I right in saying? So I guess the 500 people had to come from that area. That's a great amount of people who were willing to be part of it.
Plymouth it looks like a small town, but it's actually 300,000 people. So I suppose 500 is
it's not that much, yeah. But it's not like Manchester or London or Birmingham, is it? So in terms of the pool of people, it's not as big as it could be. But that's a great amount of people, yeah. So a question from Lorna Wing. Have you seen a cumulative beneficial effect for those with OCD and for those with Parkinson's?
Yeah, so not that we. So first of all, we haven't started that long ago to have really longitudinal data. We will have the data up to now, but we have observed cumulative effect, but not in terms of brain plasticity necessarily. So in terms of brain plasticity, what you can observe is this change in chemical concentrations of certain metabolites in some part of the brain, or connectivity change, and then it goes back to baseline, and then you're just reforming that window again and again. But in terms of symptoms, that's what really puzzled me at the beginning is that the symptom reduction was much more long lasting than actually the effect that we were observing, strictly speaking, only in the brain. So so that really is fascinating to me, is the fact that because maybe participants have experienced this state of calmness and of where maybe the intrusive thoughts will be there, but they don't have to act on it. That gives them an experience to hold on to, and therefore it translates into something that's much more long lasting. That's very fascinating, but I don't really know exactly how this is formed.
So it's like the psychology behind having a period of time where the OCD didn't affect you actually gives you more of a positive outlook on how you can get to a place where it's not affecting you even longer. And the more that happens, the better.
That's right.
The better situation you're in. I get that. But the actual effects, the neuroplasticity, you think probably just returns to how it was when you stopped having the ultrasound.
It is quite clear to us that there is a return to baseline in terms of, say, synaptic excitability, or so what we call intrinsic excitability of the tissue. And I guess it's great because the neuron cannot continue to fire, too much for too long. But so that will go back to baseline. But it had done its magic during, during the 1 hour where it's able to communicate with other brain region in a way that's a bit more on the healthy range, if you see what I mean.
Yeah. Lorna's also sent another message in. Do you have a view on the benefits or not of TMS and the flow headsets? I know someone who used one of those flow headsets. And I mean, I think they thought it was working, but you could only use it, the one that they had, twice a week. And it just felt like the benefits were so small. But it's a different, it's obviously type of technology, isn't it? Do you know anything about those flow headsets?
Yeah. So TMS is very powerful. It can elicit very strong effects, but it's cumbersome and it doesn't really go very deep in the brain. So it's usually limited to the dorsolateral surface of the cortex. Therefore, you are more, my guess is that you would be targeting the dorsolateral prefrontal cortex, for example, here and here. And it's very heavy, and you need, usually you need someone to operate the machine. And it's electricity. Well, it's a magnetic field that therefore is going to be, inducing some current. So again, it's different types of communication with the neurons or the brain cells, and it's limited because it cannot go deep and it's heavy and so on. But TMS is very powerful. There's no doubt about it.
When you're talking about TMS, that you can't go too deep, and perhaps the same with the flow headset, does that mean the OCD circuit that you're trying to affect is actually a bit deeper, and maybe it works for, say, depression because it can affect those parts of the brain, but not when you're trying to get deep to OCD?
Well, even depression, I would say the key region in the brain for depression is called the subgenual anterior cingulate cortex, and it's a very deep cortical region that you would traditionally you wouldn't be able to target with TMS. So indirectly, you're trying to hit that region by mean of nodes of a circuit. So that's what they do with depression. And exactly, you're absolutely right. The deeper you go in the brain, the more you interact with those nuclei that have very specific role, that are much more impactful, I would say. If you modulate those little nodes, you're more likely to have results because they are more ancient. I don't really like to say that, but they are just more evolutionary speaking. They are those core parts of the brain that we share with a lot of species. So they are much more, they will be the same across participants, whereas the cortex is a very complex, part of the brain that we don't fully understand that well. And the variability across participants is immense. So if we were to target everybody in the same part of the cortex, it's very unlikely that it's going to be effective.
Time is against us. We've got about 5, 6, 7 minutes left. I just wanted to ask about you and why you're doing this work. What is it that inspired you to get into this? Because I don't think you've always been a neuroscientist, have you?
No. Actually, no. I started as an engineer. I was working in brain-computer interface for a little while. But to be fair, like a lot of people on Earth, I have myself suffer from certain mental health issues, and I have people that I love very much that have been affected very, very severely by certain forms of OCD and addiction. And I think I'm just growing into. Of course, I care about the brain. I've always been fascinated by the brain, which is to me the most complex organ in the world, in the universe, and we still don't fully understand it. So cracking the brain has always been a bit of a passion to me. But now, the more I realize that to what extent that can transform people's life, the more I am, yeah, I feel like almost personally invested as well. Like we really need to do this seriously. We really need to move the field forward.
I mean, so
Because
you go into work every day thinking I can change lives, or is it just it's another job?
No, so I'm super passionate by what I do. I wake up every morning feeling extremely grateful that I am working at the cutting edge of something that potentially could change the world. Obviously, it's not in my head every day,
Yeah.
but when I speak to people like you that are just interested, or when I reflect a little bit on the bigger picture, it does sometimes really hit me that this is important. And I'm just very grateful to be very lucky to be at the right place at the right time, really.
I mean, when you say change the world, just explain. I mean, that sounds big.
Well, 1 every 4 person worldwide is suffering from a brain disorder. That is a lot of us. And as I said, it's almost certain that all of us through our lives have experienced sometimes periods of depression, or we have seen people struggling. So yeah, maybe it is a big word to say change the world, but ultimately we want to be happy, right? we just want to alleviate suffering, and I think that's one way to potentially achieve that.
In 10 years' time, maybe if we're doing this interview, maybe 50 years' time when neither of us are here. You're a bit younger than me, I think. I won't be here in 50 years' time. But when someone is doing this interview in 50 years' time about ultrasound, what will they be talking about? 10 years, 50 years' time, what do you think we'll be talking about here?
I'm really hoping that in 10 years' time we have translate that into the real world, and there is places where you can go, clinics. Hopefully that will be reimbursed, and people can actually engage more seriously about their brain disorder than. Well, now there is ways, but obviously there's a lot of trial and error, and we know that it's not very effective. So I do really hope that in 10 years, at least it will be in the clinical world, and people will be able to use it. Whether or not it will be something that you use at home with your phone, I don't know. But it is possible that we can go towards that, especially with the advancement of AI and so on. It is also possible that we are going to be in an era where with a fewer data we can tailor and personalize treatment. That's what I was saying at the beginning, like I still need a brain image, I would still need a skull image. It would be great if I could see how you are performing certain decision making tasks, because that will inform me about your brain. And this is where I would like the field to go toward. It's personalized medicine, personalized neuroscience. Maybe in 10 years, we will be in an era where a treatment will be sold as everybody received the same protocol and in the same brain region. Maybe in 50 years, I can have a treatment that's personalized to your need, to your brain.
I suppose in the same way that cancer treatment has changed from being sort of quite blanket, the way it's a lot more targeted.
Yeah, that's right.
We'll hopefully be getting in an ultrasound can play a role in that. We'll be doing that in mental health treatment. As I say, time is against us. We're near the end. I just wanted to mention some of the messages because you can't see them coming in. Lots of people really appreciative of the work you're doing, but also the talk you've given us today. So we've had one great talk. Made of Millions, who are hosting this. Thank you for another great conversation. Lorna, who we heard some questions from. Thank you so much, Elsa and Sean. It was illuminating, insightful, and encouraging for the future. So grateful to you both. Margarita, we heard from her earlier. Thank you very much, Elsa and Sean, for such an amazing hour. Lots of other messages, just really positive messages about what you're saying. But I think what's really important, positive about the future. Another one, great talk. Paul Ram, though, I want to just leave you with his one just at the end, his message at the end. He says, because this will inspire you. I know you said you get out of bed every morning and you feel really, well, not every morning, but you feel grateful for what you do and what you're the work you're doing and what you can do and the potential. But if you ever feel like, oh, I don't fancy doing this anymore, Paul Ram's message says, I hope a cure is found. I've had 3 major onsets of OCD. It's pretty much ruined my life and I'm still suffering. And that kind of makes me really sad to read that. And I've read so many messages like that when I've done these webinars and when I've met people with OCD. It is ruining people's lives. And so the work you do is absolutely crucial and really important. And I know it's at the early stages, but hopefully we'll be talking about ultrasound in a way that it is actually transforming lives, people like Paul's lives. And he's also messaged to say thank you all for what you've done today. So I don't know, just in the sort of 10 seconds we've got left, how does that make you feel?
Yeah, no, it's I know that what we're doing is important, and I will continue.
Yeah. Well, thank you.
Thank you so much for your time.
Yeah, no, well, you're thanking me. Thank you so much for your time, for being our first guest on the OCD Conversations. Elsa, it's been really good. And also, probably more importantly, thank you for the work you do and hopefully the work you'll be doing in the future to change people's lives with OCD. And to everybody who's sent messages in and who's been watching today, thank you so much for joining us. We'll be back in a month's time with another guest like Elsa, and we'll be talking about new treatments for OCD. But for now, thank you all very much indeed.